Hello, everyone. On behalf of BTL, I welcome you to this meeting. The topic for today is cardiopulmonary exercise test. And our speaker and friend is Dr. Stefan Bosnatu, which is a cardiologist with a PhD in cardiovascular rehabilitation in one of the most important hospitals here in Romania. Also, Dr. Bosnatu is a vice dean within the Faculty of Medicine in the University of Medicine and Pharmacy in Bucharest, Romania. And I'm proud to say that it's the Romanian National Young Ambassador for Preventive Cardiology for European Association of Preventive Cardiology. This is just a small part of Dr. Bosnatu resume, and I'm glad that it's our speaker today, a person who has a clear vision of what preventive cardiology means, and he is also experienced in working with CPET, mainly with the BTL cardiopulmonary exercise test device. So only one request: if you have any question during this meeting, please ask it. You can write it on chat and we'll answer at the end.
Okay.
Dr. Bosnatu.
I will take the discussion from here. Thank you very much, Stefan, for the kind introduction. Thank you all for being with us today. As Stefan mentioned, I'm a cardiologist. I work in Bucharest at the Baghdazar Arseni Hospital. It's an emergency clinical hospital doing cardiology activities, starting from acute care to interventional cardiology and finishing with the part of cardiac rehabilitation, which I think that completes the entire cycle of cardiac patient management. Today, as Stefan asked me, it's my pleasure and honor to have so many of you listening to me to discuss about the Romanian experience, I would say, in terms of cardiopulmonary exercise testing use in real-time scenarios, because we are speaking here about how we practically use it. Most of the activities that we have within the hospital, given the fact that it's an emergency hospital, are related to heart failure patient management, ischemic heart disease patient management. And on the other side, there are some activities that cover also preventive cardiology and using CPET for optimizing sports performers for different type of athletes. So as Stefan said, during my presentation, please interrupt me, please put questions, please discuss with me, because I'd like us to have an interactive discussion and also maybe to see your vision towards the implementation of CPET exercise testing systems into Indonesia, as I would say that the use of cardiopulmonary exercise testing, it's not so extensively used throughout the world. So I'll start sharing my presentation now. Okay. Okay, please tell me if you see the screen.
Not yet.
Not yet, okay. Maybe now?
Now it's perfect.
Okay, so the topic, it's about CPET interpretation. The content that we are going to cover, it's related mostly to the indications for CPET, the patient and system preparation. If we speak about the BTL stress effort testing system, also about the CPET general parameters that are evaluated and the mostly used ones, and about the interpretation of the CPEX results. I will start basically by speaking about the normal ability to perform physical activity exercise, which is critically related to cardiovascular system's capacity to supply the oxygen to the muscles and the pulmonary system's ability to clear carbon dioxide from the blood via the lungs. Basically, the cardiovascular and respiratory systems work together to provide both the delivery system of oxygen and the removal system of carbon dioxide from tissues. That's why I also usually say that we don't have cardiac rehabilitation and pulmonary rehabilitation. Basically, we have one concept that covers cardiorespiratory rehabilitation in reality. Usually there are 4 processes that occur to make this happen. Well, the first process is related to the pulmonary ventilation, or the movement of the air into and out of the lungs. The second step is the pulmonary diffusion, or the exchange of oxygen and carbon dioxide between the lungs and the blood. The first step is related to the transportation of oxygen and carbon dioxide in the blood. And the fourth step is related to the capillary gas exchange, or the exchange of the oxygen and carbon dioxide between the capillary blood and the working muscle. The first 2 processes, which I mentioned, are referred to as an external respiration because they involve the movement of the gases from the ambient into the lungs and then the blood. The fourth step basically is commonly termed internal respiration because it involves gas exchange between the blood and the tissues. These processes are linked by the circulatory system, and here comes the role of the cardiopulmonary exercise testing, which is valuable because it's taxing the mechanism responsible for external and internal respiration by exercise and can frequently reveal abnormalities that do not appear at rest. The increase in oxygen uptake, I would say, by the working muscle is facilitated mostly as a most important factor by an increase in the cardiac output. Cardiac output, which is normally termed heart rate times the stroke volume, which may increase to up to 6 times than at rest. The cardiac output is also redistributed away from non-active tissues, from the splenic and renal to the skeletal muscle during physical activity, which basically facilitates greater oxygen delivery to the muscle. Another concomitant increase in blood flow to the lungs occur both by increasing this cardiac output and also by the vasodilatation of the pulmonary vessels. As you know, we have a dead space that is diminishing during physical activity. A greater extraction of oxygen from the blood also occurs as the blood perfuses the muscle, which results in a widening of the arteriovenous oxygen difference. In normal subjects, we also increase the minute ventilation during exercise to increase their working rate, and basically taking into consideration that during inhalation, only part of the tidal volume of air reaches the alveoli, where gas exchanges takes place in the lungs. The air that remains basically in the respiratory passage that does not participate in gas exchange is known as dead space volume, has a very important role in distinguishing between different pathologies that appear. If we speak about the general indications that cover the spectrum of CPEX use, we would say that we use it for evaluating the exercise tolerance and functional work capacity. We also use it for determining the evolution and the prognosis of heart failure patients. the evaluation of the evolution of pulmonary obstructive chronic disease and interstitial lung diseases. But generally speaking, I would say that these are the main principles of using CPET. If we have a patient with a known cause of dyspnea, the CPET would usually guide us into determining if the cause is cardiac, if the cause is pulmonary, or it's something central. If you want to evaluate the degrees of cardiac insufficiency and its prognosis, it's a very good indicator in order to see exactly where the patient is and in order to allow a proper cardiac rehabilitation for the specific patient. In sports medicine, we will say that we basically use to define the personalized way in which an athlete should train, and also to see if this athlete has possibility to further advance in his career. In social medicine, we would say that after an event, a cardiac event or a pulmonary event, we evaluate basically the autonomy of the patient and the capacity to resume his activities. And also, as I mentioned, we are also an emergency clinical hospital with a lot of surgery. And here comes an important role of the CPET test in order to evaluate the cardiovascular risk more accurate than basal traditional risk scores like a Lee score, for example. In terms of the contraindications and the aspects that would refuse a patient from doing a cardiopulmonary exercise testing, I would say that it's quite important not to perform such a test 7 days prior to myocardial infarction. If the patient is unstable, take into consideration unstable angina, recent syncope events with active myocarditis or pericarditis, with severe valvulopathies and uncontrolled heart failure. On the other side, it's quite important if the patient has a mental desaturation less than 85% to not put the patient into an exercise testing because his condition will aggravate. And if there are mental impairments, of course, it's not properly correct to put the patient in terms of evaluation. Some relative contraindications are related to the disease of the left main, which is a little bit tricky in terms of the recommendations for physical activity for this sort of patients. Moderate to severe valvular heart disease, which could become symptomatic during effort. If the patient has resting or high blood values, it's very important to control them before putting the patient into doing the CPET test. Also, in terms of atrial fibrillation with a high degree, with a high atrial rate or a high degree atrial ventricular block, it's wisely not to initiate the test with this sort of patient, and it's important to closely monitor a patient when it has hypertrophic cardiomyopathy and significant pulmonary hypertension for the risk of arrhythmias during the stress test. In terms of the indication for termination, the CPET test, usually the indications are related to the ECG changes, because most of the CPET test, all of the tests that we are performing into the hospital are done also with the ECG monitoring. And if there are signs of ischemia, such as ST elevation or ST depression, which are significant for angina, it's important to terminate the test. Also, if there are arrhythmias or atrioventricular conduction disorders that appear during the stress test, it's important to take into consideration stopping the test before aggravating the situation. If the patient has increased high blood pressure, I would say that in normal patients over 220, 240, and in sports and highly trained athletes over 250 millimeters of systolic blood pressure, it's important to terminate the test in order to reduce the risk of neurologic affections, I would say, because it does silent when the blood pressure is over 220, 240. We all know that it produces silent ischemia problems within the brain. Also, if the patient has desaturation of loss of coordination, dizziness, of signs of respiratory failure, there are signs to terminate the exercise testing. In terms of the equipment that we are using for the cardiopulmonary exercise testing, the equipment is more complex than the basic ECG stress test, because it has also this cardiopulmonary module that a part of the cycle ergometer or treadmill, depending on what you use. Basically, it has a flow sensor, it has an oxygen and carbon dioxide gas analyzer. It has a different software that is needed to for the calibration activities, and it has aspects that are related to the pulmonary evaluation. It's quite important before starting each cardiopulmonary exercise testing. It would be, as a general rule of thumb, every time you perform a stress test, to ventilate the room and to do the calibration of the device. Nowadays, as the BTL system also has, all the modern cardiopulmonary exercise systems contain rapidly responding oxygen and carbon dioxide sensors that allow for the calculation of the oxygen uptake and carbon dioxide output at rest, during exercise, and during recovery, as frequently as brief by brief. Normally, basically, the cardiopulmonary systems, as I said to you, should be calibrated immediately before each exercise test. I would mention to you that, unfortunately, we don't have the time to do this step as recommended by the guidelines. We only do the calibration at the beginning of the day, because there is a step where you need to ventilate the room. Afterwards, you need to start the analyzer and leave it for 30 minutes in order to calibrate. And after doing these two steps, basically you start the general calibration. It's quite important that you have a ventilation system in the room, that you are having the stress test, in order to ensure that the room is properly ventilated, or to have enough windows in order to ensure these ventilations, because all the sensors are quite sensitive, and most of the time you have difficulties in obtaining the good and efficient values if you don't have enough time and enough windows, not time, enough space for the CPET and enough windows to ventilate the room. Because gas analyzers are basically prone to drift, and this could lead to serious detection errors. Fortunately, all the commercial available systems have convenient calibration procedures controlled by microprocessors. This is the image that shows basically the steps needed for the calibration of the device. We start with the ambient carbon dioxide analyze. Afterwards, we go to the flow sensor adjustment, to the sensors that determines basically the oxygen and input and carbon dioxide output, with its calibration by using the gases that are into the I would say I don't know exactly how it's called, the gas pump that has also a specific concentration of nitrogen, oxygen, and carbon dioxide in order to equilibrate and to get to the zero, the flow sensor, in order to properly determine the current amount of gases. And afterwards, it is the pumping syringe that is used in order to calibrate through these sensors the flow for resting conditions and also for exercise conditions. In terms of this, I would say in terms of the maintenance and quality control of the measurements that you are doing with the cardiopulmonary exercise testing, I'd say that it's important that the validation of the CPET system to be performed on a regular basis. The gas exchange measurements are highly reproducible within a given subject if testing methods are consistent. One method that is also described in the official position papers of the American Heart Association and also the European Association of Preventive Cardiology, it's related to validate the system's performance with test laboratory on staff members at a match to maximal work rate on a periodic basis. The recommendation is to do this every 4 to 6 months. It is recommended basically that several staff members to participate in this process, each of them using a slightly different steady state submaximal work rate. As long as the subject is in a steady state with a constant metabolic rate, the VO2 and the other cardiopulmonary exercise testing variables should be reproducible. 4 to 6 minutes of constant low to moderate intensity exercise is required for most individuals to achieve a steady state. The acceptable limits of variation for the VO2, VCO2, and the VE for a given steady work rate are shown in the table that I depicted you. And these are somehow with a plus minus around plus minus 5 to 6%. In addition to being reproducible, VO2 should fall within an acceptable range when compared to estimated VO2 based on the external work rate. The recommended values for steady work are also best depicted by the American College of Sports Medicine, and you can find them in a document that I'll put at your disposal after this session. I think we have a question. We have something in the chat.
No, it's we only ask for the presence, so each participant should fulfill this.
Okay, sorry. Speaking now at the part of the patient preparation. I think you all know how the patient should come when performing a stress test. It's important to be in comfortable clothing and appropriate footwear. I would say that the medication should be decided in order to be taken or not taken. If we speak about patients under medication, depending on what the specialist would like to see during the effort stress test. It's important that patients that come from outside the hospital should stop smoking at least 8 hours prior to the testing, especially for athletes in order to evaluate optimally their performance. It's quite important to not do any heavy training in the day of the testing. I would recommend 24 to 48 hours before testing to do this resting period before the stress test in order to have the most appropriate results. And related to the meals, it's very important to avoid eating 2 hours prior to the test. A very important step before doing a cardiopulmonary exercise testing is related to the pre-test respiratory function testing. This is an important step which is used for evaluating basically the ventilatory reserve of the patient, and it's an important aspect for basically quantifying the impact that the lungs have on the dysfunction on the results that the patient has obtained during the session. I would say that all the CPETs and the BTL has a very nice function. Usually you are able to do this spirometry before the exercise testing, and it takes your results and implements it in the system. Also, if you have healthy subjects, the system also has a general database in which you have the predictive values for the FEV1. And somehow you could, and we usually, I would say, in reality, bypass this this step when performing the CPEX exercise testing, because they take the information from the database from the general Caucasian population. So this flow volume loop that is shown basically in the screen, it's used in several ways. FEV1, like I said to you, which is the forced expiratory volume in 1 second, it's used for the calculation of the workload increment. Also, FEV1 may be used, as I told you, to estimate the maximal voluntary ventilation using a formula which is FEV1 times 40. And this allows the closest calculation that has been demonstrated to be the gold standard when it comes to measuring the MVV over a period. And also as a baseline measurement of inspiratory capacity and the expiratory lung volume when evaluating exercise flow volume loops. It's quite important to take into consideration during doing the spirometry. Assessment of exercise capacity typically is performed on a motorized treadmill or a stationary cycle ergometer. Treadmill exercise is generally the preferred way for active normal subjects. Untrained subjects will usually terminate the exercise during the treadmill with a higher VO2 than doing this on a cycle ergometer. It's important to take into consideration the aspects that I've mentioned into this picture. That the cycle ergometry permits a better work rate management and also the work rate association with the monitored parameters. Also, you should take into consideration that the cycle ergometer allows you to have a more accurate ECG recording in order to detect the ST segments changes. In terms of safety, the cycle ergometer is safer because it's basically the vertical position that somehow reduces the risk of vagal reactions of the patient. Also, if you have a recumbent bike, it's much safer than a vertical bike because it's like I would say a sofa in which the patient is performing, and it's more comfortable also for the patient. It's an advantage also for the obese patients that the weight bearing it's not felt during this this activity. Still, as I told you, it's important to take into consideration that when you evaluate the athletes, it produces VO2s, which are generally speaking on average 10 to 20% below the treadmill peak VO2 that has been obtained using the treadmill. And now, if we come to the point of the interpretation of the CPEX results, and we will basically start after doing the CPEX test. We will start by searching if the assessment produced a maximal effort for the patient. And it's important to see that the oxygen VO2 curve has reached to a plateau to the end of the registration. Also, we need to take a look of the predicted maximal work rate that has been achieved and its relation to what the system says, because as I was mentioning earlier, related to the spirometry and FEV1 database, also the system has calculation model for the predicted working rate when using the cycle ergometer. Also, to take into consideration the predicted maximal heart rate if it's achieved, or there is a big heart rate reserve available, which we are going to talk about a little bit later. If there are evidences of ventilatory limitation related to what I've told you about the maximum minute ventilation measurement, and if we have reached it during the effort test, and also to take a look at the respiratory exchange ratio and to see if the values are greater than 1.1 to 1.2, indicated basically the near maximal or maximal effort test. The general CPET parameters are, I would say, in two categories. There are non-invasive measurements that are detected by the bike, that are detected by the flow sensor, and also there are invasive measurements that can be taken apart of the non-invasive ones in terms of when basically evaluating more advanced athletes, and we would certainly want to correlate the non-invasive parameters to the invasive one. When speaking about the non-invasive parameters or variables, we would say that the work is quantified by the work rate that has been performed, and here the cycle ergometer has a clear advantage on the treadmill because we have the specific watts that have been performed. The metabolic variables that are related to the VO2, VCO2, respiratory exchange ratio, and anaerobic threshold. Also, a metabolic invasive parameter is represented by the lactate, which is basically obtained by doing an ABG, usually from the ear of the patient, and I would say that we did 2 times this ABG monitoring with an arterial line in order to assess a sport cyclist, and this is not quite frequently performed during real life. Also, the system has the possibility to introduce the ABG results related to the lactate, the pH, the PaCO2, because you would have to take them step by step. When you define basically the protocol, at every step of the protocol, the evaluated protocol, you will have to take the ABG and to correlate the variables. The cardiovascular variables are the heart rate reserve, the ECG, the blood pressure, and the O2 pulse. The respiratory variables are the minute ventilation, the tidal volume, the reserve volume, the PaT-O2 and PaT-CO2, and the pulmonary gas exchange are related to the saturation, are related to the VCO2 equivalents, the VO2 equivalents, and the invasive ones related to the oxygen saturation and the arterial oxygen pressure from the concentration from the arterial blood, the alveolar arterial differential, and also the VD upon VT, which is the dead space on the tidal volume, which represents generally the dead space volume within the lung. In terms of acid-base variables, these are also taken invasively from the ABG, represented by pH, PaCO2, and bicarb. The symptoms, which are quite important in determining basically the nature of the, I would say, the reason for stopping the test are quite important to be assessed, and the most frequent of them are related to dyspnea, leg fatigue, or chest pain. Now, when we would speak about the normal ranges for the general parameters, we would have to take into consideration that for the maximum heart rate, usually we use the general formula, which is 220 minus the age of the patient. The maximum tidal volume, it's about 60% of the forced vital capacity of the patient. The minute ventilation at peak exercise should go to up to 80% of the measured maximum voluntary ventilation. And this is the aspect that I was previously mentioning related to the connection from the VE to the MVV in order to detect a pulmonary limitation. The O2 pulse, which basically is a surrogate of the stroke volume, it's important to be 80% over the predicted value of the patient, but as a general rule of thumb, it's important to be over 10 milliliters per beat. The pulmonary end tidal CO2 values normally are around 45 to 42 millimeters of mercury, but basically after the ventilatory threshold, they should start decreasing normally. Also, the pulmonary end tidal O2 volumes should be around 100, 115 millimeters of mercury and should rise these values after the ventilatory threshold. Given the fact that after we get to the ventilatory threshold, we aren't able to use much more oxygen, and this is the reason why the end tidal oxygen volume starts increases, because it's not being used. We go into the anaerobic state, and we tend to have a higher concentration of end tidal O2 after the ventilatory threshold. The respiratory exchange ratio, it's a very important factor because it also shows us that we reached to the limit. It's one of the ways that shows us that we reached to the limit of the exercise. And as I was mentioning earlier, if it goes over 1.1 or 1.2, then it's a good sign that the subject has performed its maximal effort. And it's also important when differentiating the pulmonary limitation a part of the cardiac limitation, because in terms of pulmonary limitation, there are times, most of the times, when you do not reach a respiratory exchange ratio of 1, that basically you do not reach the anaerobic threshold due to the pulmonary limitation. The oxygen saturation normally should remain constant, should be over 95%. The abnormal thing is to say would be if there is a decrease of the oxygen saturation with more than 4% from the baseline of decrease, which is not recovered easier after the hand has been ungripped from the bar, if we do the treadmill or the bicycle test, and somehow this could be signs for abnormal oxygen absorption and signs of lung problems. In terms of the VD and VT ratio, as I mentioned earlier, which is represented basically by the volume of the dead space within the lungs. Normally, with effort, this ratio, which is around 0.25, 0.35, this ratio should decrease. And this is given the fact that normally there is a ventilation perfusion mismatch at the apical parts of the lungs that during effort, it's equilibrated, given the fact that also the apical capillary is open. And this is mainly most of the reason that normally during effort, when we have a good heart and the heart is able to ensure the necessary cardiac output also for the lungs, and we have a normal lung tissue, by the distension and the opening of the and the proper perfusion of the apical alveoli, the dead space should decrease. And this is the normal response during cardiopulmonary exercise test for a normal subject. In terms of the VCO2 equivalence, which is the ratio between the minute ventilation and the VCO2, the normal values are around 24 to 44, and this is basically a thing that it's not clearly shown where should it be measured. We are measuring it at the anaerobic threshold, because somehow this is the point where the minute ventilation slope shifts upwards steadily, and also the CO2 also starts shifting up. And there are other centers and other recommendations that this should be an average of the entire monitoring period. In terms of the oxygen uptake efficiency, which is the VE over the VO2 ratio, the normal limits are around 22 and 42 in normal subjects, but here there isn't a quite important thing, because the VE to VCO2 is quite an important predictor in terms of mortality, given if you have heart rate or pulmonary disease, heart failure, or pulmonary disease. But the VE over VO2, it hasn't been proven to be a reliable indicator for morbidity and mortality. And at the end, we will go to the VO2 max, which should be at least over 80% of the predicted values for the subject based on gender, age, and height. Now, getting into a little bit more detail, when speaking about this oxygen uptake, VO2, we say that the maximal VO2 is an important measurement, because it is considered to be basically the metric that defines the limits of the cardiopulmonary system. It is defined by the Fick equation as the basically it's the product of the cardiac output and the arteriovenous oxygen difference at peak exercise. Cardiac output, as I mentioned earlier, it's mostly calculated by heart rate times the stroke volume. Although the VO2 max is measured in liters of oxygen per minute, the most usual way of expressing it's in milliliters of oxygen per kilogram of body weight per minute. Basically, this facilitates the inter-subject comparisons, because it's quite different to have a VO2 of I would say 2000 milliliters at 150 kilograms than having a VO2 of 2000 milliliters at 80 kilograms. And if you subtract it by kilogram, you would see a huge difference. In addition, exercise capacity, particularly when estimated from the work rate achieved, also acts as somehow as a measurement of his fitness. Another transformation is related to the transforming 3.5 milliliters in METs, and you would be able to define basically the MET capacity of the person doing the specific activity. It's important to take into consideration that during the VO2 measurement, there are two notions used. There is the VO2 max and the VO2 peak. Usually, when the subjects are healthy, we manage to see also the VO2 max, because this is when the VO2 curve gets to a plateau. And when it gets to a plateau, it's the sign that this is the maximal VO2 that the subject has managed to do. On the other side, the VO2 peak, it's when the patient reaches the upper limit, it's not capable of continuing and supporting for at least 10 to 15 seconds. That limit of effort is, he asks for stopping the exercise, and you stop the exercise and you don't manage to see basically the plateau, then you consider that eventually you would reach to the VO2 peak of the patient. In terms of the predicted normal values that I was mentioning earlier, it's important to have it over 80 to 84% than the predicted normally, and to take also into consideration that in the general populations, if you have a VO2 over VO2 max over 20 milliliters per kilogram, if we speak about the general population, then it means that the subject has a good effort capacity. If the VO2 is between 15 and 20 milliliters per kilogram, then it's a mild reduction in the tolerance to the effort. If the VO2 is between 10 and 15 milliliters per kilogram, then it's a moderate reduction in the capacity, the functional capacity of the subject. And if we speak about screening a patient for his risk of surgery or transplant, for example, if the VO2 is below 10 milliliters per minute per kilogram, then it's a patient which is severely affected in terms of cardiopulmonary fitness, with a high risk, and basically with the indication to go towards a transplant if we speak about transplant. Also, we should have in mind, as I showed on the slide, that the VO2 max can get onto 80 milliliters per minute per kilogram, which is obtained in highly trained athletes, especially in cyclists, because they have the general adaptation of the enlargement of the left ventricle cavity, and also the dilatation of the right ventricle. And I think it's not a question, sorry. And basically also this is quite important to see that from these 20 milliliters, where you say that it's a good condition, you might expect someone who wants to train to reach up to maybe 50, 60 milliliters per minute when we speak about recreational athletes. Okay. The cardiac parameters. As I mentioned earlier, the cardiac parameters are mostly related to the cardiac output that should increase linearly with the increase of the VO2. Basically, initially, the cardiac output increases both by heart rate and by stroke volume, and later it gets increased exclusively by the heart rate. The predicted maximum heart rate of the patient, as I said to you, it's 220 minus age, or 210 minus age indexed with 0.65. Normally, the patient should achieve at least 85% of the age predicted, 85 to 90% of the age predicted. And also we have the parameter, which is the heart rate reserve, which normally should be less than 50 beats per minute. This is not the case for patients which are under beta blocker medication for rhythm control. And that's why I said that when we perform the stress test, we need to take into consideration the reasons for performing it. But this is a quite important factor when we speak about normal subjects, or at least normal at the beginning, when we are searching for abnormalities, to see if the patient manages to reach this maximal heart rate, in order to ensure that the heart has performed as efficient as it is trained at the moment. I'm coming now back to what I mentioned to you earlier related to the Fick equation that basically serves as the foundation for calculating the VO2. And I've put you this slide in order to better understand the relationships between the heart rate, between the stroke volume, and the oxygen concentration between the artery and the venous system. It's important to take into consideration that the VO2 it's highly affected by dysfunctions of the sinus node, by dysfunction, by administering different rhythm control medication. Also, the stroke volume is impacted by the different cardiomyopathies, the level of heart failure that the patient has. If we have contractility problems related to ischemic heart disease or other contractility problems. And basically, under the parentheses, it's important to see that it's extremely important to take into consideration the anemic level of the patient when expecting a VO2 result and when evaluating the VO2 result of the patient. And also to bear in mind the pulmonary capacity it's closely related to the oxygen concentration that gets into the arterial blood. But also, when we go on the other side, it's important to have in mind that we also have the skeletal muscles with the absorption capacity of the oxygen from the blood that could be changed in different conditions and in different, I would say, muscle disorders, but also in different situations that, for example, in sepsis, when the absorption of the capacity of extraction of the blood, the oxygen from the blood, is severely diminished. Normally, this difference between the arterial oxygen and venous oxygen, speaking about the extraction capacity of the oxygen in the muscle, it's around 80%. So it's quite important to take into consideration this aspect when evaluating these patients, because there could be some misleading problems on the other side, not on the heart or on the lungs.
I think we have a question.
Okay, yes, thank you very much, Maya, for the question. The question is, there a significant difference between VO2 max and VO2 peak in terms of functional capacity, because most of the time patients are not able to achieve plateau. Thank you. Yes, indeed. In terms of, I would say that in terms of the general population, there is not a significant difference between VO2 max and VO2 peak. And this is the reason why in general population, most of the subjects aren't able to support a plateau level of the VO2 max, because the resources and the resources are exhausted when we speak internally about the muscle, and they are not able to hold it anymore. But somehow it would be quite important when we speak about athletes to see exactly what is the VO2 max and what is the VO2 peak. I would say that it's quite important, because when we reach to the VO2 max, we reach also to the end point of the exercise test. And when we have we will speak later about this aspect, but I'll mention it also at this moment. When we reach to the anaerobic threshold, we have a first layer on the subject's cardiovascular performance. When we reach to the end of the evaluation to the VO2 max, we have the VO2 max level that has been achieved that could be a little bit higher than the VO2 peak. And in order, we will need, when evaluating these functions, we will need to see exactly at what ratio of the VO2 max has the anaerobic threshold happened. Usually, in general population, the anaerobic threshold happens at around 55 to 60% of the VO2 max. If we speak about deconditioned persons, they tend to go around 40%, because if we fall below 40%, then it's a problem when we speak about the anaerobic threshold. If the athlete is highly trained, then this anaerobic threshold goes up and it can go to 90% of the VO2 max in highly athletes, Olympians, athletes. So somehow these are, I would say, more refined indicators in order to see where is the training of the athlete going and how he is evolving. And that's why I said that in general population, basically, it won't make a big difference, but I would say that in sports performance, it could make a good difference because you see exactly if the athlete is going in the good direction, if it's steady, if it starts to decrease the performance, because at the end, the genetics will stop at some time, and it's another good thing to use, because now we're speaking into commercial terms. It's a good thing to use the CPET evaluation in order to see exactly when should you invest more into that athlete, or when you should stop investing in that athlete because he has get to the edge of his performance. I think we have another question. I hope I was clear with this aspect. The other question is related to if we want to do stress test using CPET for the obesity patient with cardiovascular problems to know the physical fitness, what we should mention before to do the stress testing. First of all, I would say, as I mentioned to you earlier, that it's quite important to say to the patient not to smoke 8 hours before doing the test. Tell him not to eat 2 hours previously before the test. I would say that the patient needs to have at most 150 kilograms, because from my knowledge, the psychoergometers used vertical psychoergometers are around 100 kilograms, the weight limit. And I don't know if the recombinant ones are upper on this limit, but it would be useful to do this CPET test on the psychoergometer if we speak about obese patients, because there are different risks, and not taking into consideration that the patient might injure himself. If you have an untrained person with a vagal reaction, and you are alone, or maybe you are with another nurse and he is quite obese, you might encounter some difficulties in managing him during this period. So my suggestion would be to use the psychoergometer for doing this. Okay, now coming back to the anaerobic threshold. We say that basically the anaerobic threshold, or the lactate threshold, or the ventilatory threshold, it's estimate to basically to evaluate the onset of the metabolic acidosis during exercise, which is caused predominantly by the accumulation of the lactic acid within the muscle. And basically it indicates that most of the activities that will be further performed will be performed in anaerobic conditions. As I mentioned to you earlier, the average persons reach this anaerobic threshold around 50 to 60% of the VO2 max. There are several methods of measuring this ventilatory threshold. However, there is no universal agreement that exists regarding which is best. The three most common definitions, and I'll put the next slide, into measuring the anaerobic threshold are related to the V-slope, that basically it's the evolution of the VCO2 during the CPET test. Somehow you need to take into consideration that when performing the test, you normally have the minute ventilation adjusted to the volume of the carbon dioxide that you are expiring. in the initial phases of the stress test, the lungs are capable of expiring basically, I would say, no, a lower quantity of carbon dioxide than the oxygen that has been imported into the body. But when we get to the anaerobic threshold and when the lactic acidosis happens, basically we have the bicarb that has to neutralize this lactic acid, and the byproduct of the bicarb with the lactic acid, it's carbon dioxide that needs to be exported outside from the body. And this is the reason that when we get basically to the anaerobic threshold, there is a big increase in carbon dioxide that needs to be exported outside of the body, and that initial linear increase of the progressive linear increase of the carbon dioxide excretion increases abruptly and changes the slope. And basically, by evaluating these two slopes that are going, you would see that from as I was saying, from 60% of the effort, when you get in the anaerobic threshold, the slope tends to become steeper. And this somehow, if you take a look on the Wassermann plot at the VCO2 evolution, you would see that the basically that hinge point, it's evaluated as anaerobic threshold point. Another method of quantifying the ventilatory threshold is related to the ventilatory equivalence evolution. Taking into consideration that basically VE to VCO2 and VE to VO2 measures the efficiency ventilation for the carbon dioxide and the oxygen, you should have in mind that normally the VE to VCO2 ratio, as I told you, will have progress that will be changed after this anaerobic threshold happens. Given the fact that the carbon dioxide accumulates in the body at a higher pace, and it needs to be I would say exported from the body, it also stimulates the respiratory system in order to increase the minute ventilation. So we also have a VE that it's increasing, and we also have a carbon dioxide concentration that it's increasing. In comparison with by this, basically you will see that the VE VCO2 curve will have the tendency to increase, but this tendency to increase will be basically at a lower pace than the tendency to increase of the VE to VO2 curve, given the fact that normally we have oxygen that we are using into the system. When we reach to the anaerobic threshold, the idea is that we aren't able to use the oxygen, the high amount of oxygen that we are having, and there is no need to increase this volume of oxygen. And that's why the VE to VO2 slope, it's higher and it's more abrupter than the VE to VCO2 slope. And basically, when you take into consideration this evolution of the slopes, you would see that generally speaking, when the VE to VO2 slope starts to increase steadier than the VE to VCO2 slope, then this will be the point when the anaerobic threshold takes place. On the other side, the third way into evaluating basically the anaerobic threshold is related to the pulmonary end-tidal CO2 and pulmonary end-tidal O2. The general idea is that when you reach to the anaerobic threshold by hyperventilation, you would start seeing the decrease of the end-tidal CO2 concentration. And also, given the fact that the oxygen, as I was mentioning to you, there will be no need of the oxygen for the use furthermore, because you are in the anaerobic threshold and the oxygen will accumulate. Also, you will see a rise in the concentration of the pulmonary end tidal oxygen concentration. And when you see these two curves that start for the oxygen to increase, for the carbon dioxide to decrease, basically you would have to assume that this is the I would say anaerobic threshold. And taking into consideration all these three aspects, you could mark them in terms of the results, the final results of the evaluation, and then try to do an average, and you'll get to the resting expiratory exchange ratio. I think we have another question which is related to
there are many of them. First of all, how do we use the CPET for patients with neuromuscular disease who usually complains of fatigue?
The idea of the CPET using neuromuscular disease is a little bit more complex, because first of all, you need to see exactly what is the level of affection of the neuromuscular disease that the patient has. And somehow it's quite important to bear in mind that the principle would be the same. If you are ready, somehow the idea is the following: when you have a neuromuscular disease and it's not diagnosticated, then it will be a hell of a tough thing to diagnosticate it with the CPEX, because usually you'll do the test, you'll receive basically a low VO2, and you'll start wondering why there is a low VO2. If the heart is contracting normally and you have a normal heart rate with a normal stroke volume, then you'll go to the second layer of that Fick equation, speaking about the difference of the arteriovenous oxygen concentration. And if then we check the anemic levels, if there are no anemic levels, if there are no lung injury problems, basically you will start to speak about possible muscular dysfunctions. And if you know this, if you know that there are neuromuscular dysfunctions, the way you perform it the same, because overall you know how the condition is, and you can monitor the patient more appropriately if you do it at 6 months apart, the evaluation during rehabilitation. You see what is the progress of the patient. But I would say that the key aspect point, it's the one related to determining that the patient has a muscular disorder that limits his ability to perform exercise and to obtain a good functional VO2. And here it's another discussion, it's another layer of discussions, because there are cardiac output non-invasive analyzers that are being used. I don't know if BTL has them. It's a system that uses nitrogen, and which is an inert gas, and it measures indirectly the cardiac output. You see that the cardiac output is okay, and then by checking that the anemic levels are not affecting and there are no other lungs disorders, you get to raise the question if it's not a mitochondrial disorder, if it's not a neuromuscular disorder or something like this. Another questions. Using CPET. I think I've lost it.
It's I will read it. When we start to do the stress test using CPET for the professional athletes after PASCA reconstruction, like ACL injury, and when we should do the evaluation.
I say that it's not quite clear to me exactly what is the Pascal reconstruction. If the doctor can intervene directly and tell me what is the Pascal reconstruction, because I'm not aware of this this acronym in Romanian. If he can, because I would say that it's an orthopedic problem here, probably somehow, no?
I think yes, because as I see ACL injury, it's something related with the
Something like cartilage,
ligament.
probably.
Yeah.
Yes. I would say that the idea related to this CPET test for this professional athlete would be somehow related to the recommendations from the orthoped, because after finishing the locomotor rehabilitation and the strengthening of the quadriceps, if it's at the, I think it's at that region, there will be no problem to start doing the test after 3 months, or depending on the muscular rehabilitation that has been performed. And then gradually, because he will start to re-enter basically in the training periods, gradually it should start and be repeated. The idea is to perform it as quick as possible in order to determine basically the thresholds, the aerobic threshold of the patients, the VO2 max, in order to determine also the calorimetric evolution of the patient, of the subject, because also the CPET test allows you to perform calorimetric measurements, and it depends after you do the rehabilitation. Maybe the subject has increased his weight. Maybe you need also to introduce some activities in order to reduce his weight during the initial part of the training, and these activities are better performed at different heart rates zones, and these heart rate zones are clearly depicted by the CPET test during the stress test calorimetric measurements.
Okay, another question. Is there any possibility to do the CPET on post-COVID patient? If yes, when should when we should do the test, and what are the preparation that we need to do before and after for the patient and for the machine, for the CPET machine?
I would say that it's a very good thing to do the CPET on post-COVID patients, because it allows you to do a proper cardiac rehabilitation, cardiopulmonary rehabilitation, as I would say to you. And on top of that, it's quite important, and not for the doctor especially, it's quite important from our experience for the patient also, because when they see the gains that they have obtained during the 8-12 weeks of rehabilitation, it's very, very useful for their continuity of maintaining that gains. Because if we don't manage to make them maintain and adhere to healthy lifestyle, they'll come back to the current status. And related to the time on when should this CPET test be performed, I would say that we locally, after we have a COVID-19 patient and we discharge him from the hospital, at 1 week from the discharge from the hospital, we call him back to do an ambulatory CPET test. And afterwards, depending on the results of the CPET test, we start the rehabilitation, but it's a cardiorespiratory rehabilitation. And there are no, I would say that there are no special considerations related to the calibration or the preparation of the device for this sort of patients.
Okay, and last question from now. What kind of objective parameters after doing the cardiopulmonary exercise test should be observed to know the results
Okay.
of the test, maybe?
I'll do, to answer to this question, I'll put a simple graph that I have into my presentation, because I think this is probably the most important aspect that it's related to the role of the this is the one. So the idea would be the following. Generally speaking, after doing an exercise stress test with CPET monitoring, we need to define if the patient has an abnormality, if he has an abnormality and it's not only deconditioned or obese, if this abnormality is related to the cardiac part of the cardiopulmonary system or it's related to the ventilatory part. As I presented you basically the general parameters, it's important to take into consideration that the most important thing is related to the VO2. If the VO2 basically it's over 85% of the predicted, then we would say that normally the patient or it's obese or if it has anxiety or it has a mild disease, but generally speaking, it's nothing. And we will monitor him further. If the peak VO2 is less than 85% of the predicted values, then I discussed with you a little bit and said that we would need to look at the anaerobic threshold. If this anaerobic threshold is over 40% of the peak VO2, then it's in the normal range. After we take a look at this anaerobic threshold, secondly, we take a look of the breathing reserve. And the breathing reserve, basically it's the percent that the minute ventilation gets in relationship to the maximum voluntary ventilation for 1 minute, which should be basically less than 70%. So if we have a normal anaerobic threshold and we have a normal breathing reserve, then we should be guided into thinking that probably it's a poor effort that has been performed by the patient, it's deconditioned, or it's possible to have a coronary artery disease. On the other side, if we speak about a patient that does not have a ventilatory reserve, so the minute ventilation gets over that 70% of the maximum voluntary ventilation, then it's a sign that the patient has a ventilatory impairment. On the other side, if we speak about the anaerobic threshold, and the anaerobic threshold happens very early, so it happens before 40% of the peak VO2, then we take a look of the breathing reserve. We have a first problem. The anaerobic threshold happens too fast. So the heart, it's not able to pump efficiently blood to the muscle, and we get lactic acid too fast. So we go to the breathing reserve. If we check the breathing reserve and the minute ventilation, it's normal, so it's under 70% of the maximum voluntary ventilation, then it's clear that the cardiac problem is the problem that it's limiting the patient into performing and obtaining a good VO2. If also the minute ventilation it's affected, then it's a clear sign that the problem at the moment is dual. We also have a cardiac impairment, but we also have a pulmonary limitation. And the general principle when we take a look at the results of the CPET is to take into consideration the VO2. It's to take into consideration the anaerobic threshold when it happens. It's to take into consideration the ventilatory reserve that the patient has, and also to take into consideration the VE to VCO2 slope, which should not go over 44, because if it goes over 44, then it means it's an efficient exchange of the carbon dioxide from the export from the lungs. And this indicator somehow it's closely related to all of them: heart disease, pulmonary diseases, and it's an indicator of increased risk of mortality. So, in my opinion, this would be the major aspects when we speak about the general evaluation of the cardiopulmonary exercise testing general indicators.
Thank you. Another question. In heart failure patients with increased baseline heart rate baseline, can we get a mini misinterpretation of VO2 max during the CPET results analysis?
I would say that if the patient has a baseline increased heart rate, probably he will obtain a very low VO2. And a part of this this aspect, probably he will obtain also a reduced O2 pulse, which is a surrogate for the stroke volume. Basically, it will be the VO2 over the heart rate. I don't think that we will obtain basically an overestimation.
Thank you. Another question. Is the CPET still the gold standard for measuring the cardio-respiration fitness?
Taking into consideration that VO2 max basically is the gold standard in terms of the cardiorespiratory fitness, I would say that yes, the CPET it's still the gold standard for doing this.
And another question, for the patient using beta blockers, what formula do you use to calculate maximal heart rate? Thank you.
Usually, if the patient it's efficiently controlled, so in my opinion and in the general recommendations, with a good control, it means that he has the daily average heart rate around 60 to 70 beats per minute. I would say that we consider that the stress test, it's okay if he manages to go over 62% of his expected maximum heart rate. In this, if the patient is on beta blockers, it's not properly correct to tell that he didn't reach the heart rate reserve. Because if you would get him in this zone, basically you would have a different condition, which is related to the chronotropic efficiency, as I've pointed in this slide, which is basically related to the incapacity of the heart to increase the rate in order to support the necessary cardiac output. So it's, in my opinion, it doesn't make the most important thing when the patient is with beta blockers. It's that the patient tells the doctor that he is on beta blockers if the doctor doesn't know this. It's an important thing because we also have patients on beta blockers that are also athletes. And this is somehow important because you have different type of patient and you need to keep the evaluation of that patient on the same device with the same protocol in order to see exactly. It's clear that the beta blocker impairs the performance, but still if he continues to train with the same dosage of beta blocker medication, he will increase his capacity. And that's why it's important to motivate and to stimulate that person to performing physical activity, also to maintain the same protocol and to maintain the same rules through his evaluation. I usually tend to do for the sports subjects, I tend to do CPET evaluation at 1 year apart in order to see their evolution. I think I've uncovered half of the rest of my presentation. Now, if I could go a little bit further, I spoke about the oxygen pulse, which is the ratio between the VO2 and the heart rate, and it reflects the amount of oxygen that it's extracted per heartbeat. And basically, this oxygen pulse provides an estimate of the left ventricular stroke volume changes during exercise, but in assumption that the arteriovenous extraction capacity is maximal and there is no anemia present. Basically, during the incremental exercise, the relative contribution of stroke volume to cardiac output is predominantly during the initial and intermediate phases of exercises. Generally speaking, as you see from the image, it should continuously rise during the exercise, and it will flatten at the end when you also reach the VO2 max and when you reach the maximal heart rate of the patient, because in the third phase of the increase of the cardiac output is mostly related to the heart rate, and when you reach the maximum heart rate, this curve should start plateau. If you take a look at the image, the idea is that you would make a difference using CPET testing. If you have an early plateau of the O2 pulse, or you have a decline of the O2 pulse, then these are signs that basically you have impairment of the cardiac output. So you have a problem. And now here you start thinking, so the problem is related to the left part of the heart. You have a heart failure with left ventricle insufficiency, or it is possible to have also right heart problems with pulmonary hypertension, which could get you also to have an early plateau of the O2 pulse. Generally speaking, as I mentioned earlier, the O2 pulse should be over 15 milliliters for men and 10 milliliters for women. But also the system predicts the values based on the general population, and normally speaking, it should be over 80% of the predicted values. The blood pressure response to exercise, it's important to be monitored. It's important, especially for athletes, because if they go at very high intensities, I had Ironman participants that got to blood pressure values of around 270 or 280 milliliters at 100 beats per minute. And it's crucial to detect them in order to treat them and to avoid, I would say, avoid a stroke or an unhappy event during a race. Usually, the systolic blood pressure should increase with exercise, and the diastolic blood pressure should be steady or slight decrease. If the blood pressure doesn't tend to increase with exercise, it's clear that it's a cardiac limitation or it's an abnormal response of the sympathetic system. And if you see a fall in the blood pressure during the test, then it's a clear sign to terminate the test. The relationship between the VO2 and the work rate, it's quite important into differentiating conditions. In physiological conditions, there is a linearity in the increase of the VO2 over the rate of increase in the work rate, in the watts that the subject performs during the stress test. The slope of this relationship is a function of the ability of exercising muscles to extract basically the oxygen and to provide the aerobically generated ATP. In several reports obtained in healthy sedentary individuals, the slope for a linear ramp protocol test, it's approximately 10 milliliters. The general idea is that this aspect should be monitored during the stress test and at the end of the stress test, because if there is a this linear decline with less than 8 milliliters per minute, this could be a sign of heart failure. Another, I would say, another variable that should be monitored during the effort stress test, it's the ventilatory pattern during exercise. So the idea is that we have the minute ventilation that it normally increases during exercise. And it's quite important to take a look basically at the trend. Because there is a pattern that it's called, I would say, I have a lapsus in my mind. The expiratory, I don't know why I have this lapsus now. Oscillatory breathing, it came back. So it's the expiratory oscillatory breathing pattern, which is frequently encountered in women's. It's encountered also in anxious persons. The general idea is that you could have some oscillations during breathing, that it's shown also in the minute ventilation trend. The image on the A letter, it's a normal trend, basically. The image on the B letter, it's an oscillatory breathing trend. The idea is that there are resting oscillations over 15% of the resting values. That goes more than 60% of the entire exercise that has been performed. It's a clear indication that this patient has an oscillatory breathing pattern. This pattern, basically, it's also assimilated to the central sleep apnea problem, or during awake state at rest, if you speak about Cheyne-Stokes respirations. This represents basically a predictor for sudden death mortality, and it's important to take this into consideration. It's important to take a look at the minute ventilation curve on the Wassermann plot. Usually, if I said to you, anxious patients might have 30 to 40% of the beginning of the stress test with oscillatory respirations. Okay. Now we have basically the graphics that I showed you when we measured the anaerobic threshold related to the oxygen uptake efficiency and the carbon dioxide export efficiency. And this is a more clearer image that shows basically that the slope of the VE to VO2, it's steeper than the slope of VE to VCO2, given the fact that basically with higher ventilation, we need to take into considerations that the amount of carbon dioxide that are produced by the body are higher than the amount of oxygen that are inspired within the body. The other image, it's related to the diagram of the evolution of the partial end-tidal oxygen concentration and end-tidal carbon dioxide concentration, which I explained to you earlier. At the anaerobic threshold, basically the CO2 concentration by hyperventilation should start to decrease, and also the O2 concentration should start to increase. This is the general formula for the dead space, which is an important variable when we take a look at lung dysfunctions and lung abnormalities. It's quite important to take into consideration that by this formula, which is the arterial dioxide concentration minus the PaCO2 and over the PaCO2. Basically, these are ABG parameters, and that's why it's important, if you want to make sure that you evaluate the dead space, that you take the ABG of the patient. The ventilatory reserve is the aspect that I've mentioned you when it comes to the evaluation of the ventilatory limitation, the pulmonary limitation of the patient, because in pulmonary disease, the ventilatory reserve is reduced. So the minute ventilation, it's over 70–75% of the maximum voluntary ventilation. In cardiac disease, on the other side, they have a normal reserve. The ventilatory equivalent for VCO2, as I previously said to you, it's the efficiency of CO2 ventilation. Basically denotes the amount of the minute ventilation that is needed to eliminate 1 liter of carbon dioxide. It's a non-invasive measurement of the efficiency of evaluation. It's measured throughout, but reported at the anaerobic threshold when the concentration of the carbon dioxide is steady. And normally, this ventilatory equivalent for VCO2 should be less than 34. As I told you, basically the idea is that this is not a factor related to one condition, heart failure. This is a factor that is related to, and it's a problem for all the conditions, or even if it's lung or cardiac problem, it depicts the higher risk of mortality. These are for examples of slopes of ventilatory efficiency, and there are 3 examples with a slope of 23, which is a normal slope, or a slope of 34, which is at the limit, and the slope of 63. And this problem with the slope of 63, when we speak about the ventilatory efficiency, it's basically the problem related in this specific condition when we have a high VE to VCO2, we will most of the times think about pulmonary hypertension. And we speak about pulmonary hypertension due to the fact that with the increase of the lactic acid in the body, we also have the increase of the minute ventilation within the body. But the problem is that with pulmonary hypertension, with the high increase in the I would say with the high increase in the capillary pressure, the right heart isn't able to ensure enough cardiac output to support basically the need to export the CO2. And by this incapacity to support the cardiac output, then the ventilation becomes inefficient. It's not able to bring out the carbon dioxide that it's needed to be exhausted, I say, from the body. And that's why this law of the ventilation over the VCO2 export from the body, it's very, very high. And as I said to you, most of the times it's related to the cardiac output that cannot be supported by the right ventricle. Here we have an image with, just to bring to your attention, the evolution that the VO2 and the heart rate and the stroke volume and the cardiac output and the minute ventilation will have with exercise, where we should expect that the cardiac output to increase 4 to 5 folds in comparison with the rest, and also the minute ventilation to increase to 20, maybe to 25 folds with the minute ventilation during rest. This is a general image and a general plot which is obtained with the BTL system related to the notions that I mentioned to you earlier. And we have 9 plots that basically show the gas exchange, that shows basically the heart rate and the O2 pulse evolution, that shows the V slope, as I mentioned to you, the ventilatory equivalence with the VE to VO2 and VE to VCO2, the ventilation evolution, and the VE to VCO2 slope, the blood gases with the PET-O2 and PET-CO2, the respiratory exchange ratio analysis, and the VT over the VE evolution. As I mentioned to you, it's important to take a look at the VO2 that the patient has obtained at the end of the exercise in order to see if it is over 85 of the prediction values. It is important to take a look also at the load that the patient has obtained during the treadmill test, because this is another criteria of the, I would say, if he managed to reach the to a higher intensity. You will see here that you have the O2 pulse estimation, which basically, as I said to you, it's a surrogate for the stroke volume, which in this case is 40%, it's 136% over the predicted values. This is a transformation from the VO2, as I told you in the beginning of the session, into the metabolic equivalence. It's 6.6 METs. Which is a fine value for the general population, I would say. This is the tidal volume. It's 72. You should take a look here, because as I told you, you will get the comparison with respect to the maximum voluntary ventilation. And in this situation, where it's 70% of the maximum voluntary ventilation, we would say that the patient has ventilatory reserve available. So there seems to be no pulmonary limitation. On the other side, we have the VE to VO2, which is the efficiency of uptaking oxygen, which is normal. And also we have the VE to VCO2 slope, which is basically the efficiency of exporting carbon dioxide, and it's normal. The normal limit, I said, was 34. And the other aspects are related to the estimated PO2 and PCO2, which I don't take into consideration too much, because these are more related to the ABG measurements if they are taken, and the estimation of the pulmonary end-tidal oxygen and pulmonary end-tidal carbon dioxide, which are normal. And you also can see the trends, as I was mentioning to you earlier, on the Wassermann diagrams. I think we have other questions.
Yes, but I will take into consideration to continue the presentation, and will answer to all the questions at the end, not to destroy the flow of the presentation.
Okay. Now we will come to an end of the discussion, and this is the general patterns that you should pay attention when evaluating the cardiopulmonary exercise testing, because, as I told you earlier, the idea is that we do not use the cardiopulmonary exercise testing to establish a clear diagnostic. We have a tool that it's good for evaluating the general cardiovascular fitness. We have a tool that it's good for prescribing exercise recommendations for patients, even if they are sports professionals or are in rehabilitation. And we have a tool that guides us into seeing that not only the heart is the problem, but probably it's also the lung the problem, or they are separated, but it somehow it doesn't make a clear diagnostic. And that's why we have some patterns that we need to follow in order to see exactly where the patient fits. If we speak about the blood pressure, we should take into consideration that normally the blood pressure should rise throughout the exercise when we have a cardiac limitation. Basically, the same situation should happen also in pulmonary vascular disease or interstitial lung disease or in ventilatory diseases. If we think about the dead space, because as we said, we have dead space, we have the trachea, we have the bronchi, we have the apical parts of the lungs, which are that have a resting mismatch on perfusion and ventilation. We should take into consideration that in a cardiac impairment, normally the dead space should decrease because the blood flow should improve in the apical part of the lungs. The elasticity and the good functioning of the lungs should increase, I would say, the ventilation perfusion mismatch problems, and this dead space, which normally it's around 0.25, 0.35, should decrease. On the other side, in terms of pulmonary vascular disease or interstitial lung disease, due to the structural problems that we have when we speak about interstitial lung disease, or due to the I would say the limitation that we have in blood flow due to the increased high pressures in the circulation within the lungs, the dead space, it's possible to remain stable or even to increase in different conditions. And somehow, if we take also into consideration the ventilatory pattern, the idea is that also the decrease, it's variable in terms of the dead space, because, you know, in obstructive pulmonary disease during exercise, it's possible also to have air trapping. And if we have air trapping, basically, we have the possibility also to, during exercise, to increase the dead space. The heart rate reserve normally in cardiac patients, it's variable. Most of them should reach their heart rate reserve if they're not on medication, and should go at over 85% of the expected maximum heart rate. In terms of pulmonary vascular or interstitial lung disease, it's important to take into consideration that probably there won't be no heart reserve, because given the fact that we don't have enough oxygenation, we need the heart to go as high as possible in order to try to support the body's needs. Also, when we speak about ventilatory problems, the idea is that due to the fact that the lungs hyperventilate and don't change the air, the oxygen and carbon dioxide efficiently, we will be exhausted due to the hyperventilation. And basically, the heart rate reserve will be large because we won't be able to increase the heart rate to support this aspect, because the lungs will be exhausted due to hyperventilation. In terms of metabolic acidosis, if we speak about the anaerobic threshold, when we speak about cardiac limitation, we reach to the anaerobic threshold, but the pattern is to reach the anaerobic threshold, as I was mentioning earlier, rapidly, so below 40% of the VO2 max most of the times. When we speak about the pulmonary vascular disease or interstitial lung disease, basically we manage to reach the anaerobic threshold because we are capable to support also the heart rate, and we are capable to introducing the oxygen to the demands of the anaerobic threshold within the body. The problem is with the ventilatory diseases, with the pulmonary obstructive diseases, where most of the times, due to the inefficient ventilation of the patient, we are not able to reach basically the anaerobic threshold, and the patient, as I was mentioning to you earlier, with the heart rate reserve that doesn't increase due to the dyspnea and the inefficient ventilation, won't be able most of the times to reach the respiratory exchange ratio. And this is a very important aspect to take into consideration when you monitor and perform a stress test and you see that the patient has not reached the anaerobic threshold. The O2 pulse, as I mentioned to you, which is the marker for the stroke volume, it's a marker that may plateau near end exercise. As quicker as it plateaus, basically it shows that there is impairment and there is no capacity to augment basically the stroke volume. On the other side, the pulmonary vascular disease and interstitial lung disease have the same design in terms of O2 pulse evolution, and but the ventilatory inefficiency say that conducts to an increased linear O2 pulse that terminates quickly, subsequently with the termination of the exercise. In terms of oxygen saturation, the oxygen saturation should remain stable during the evaluation of a patient with cardiac limitation, but could decrease in patients with interstitial vascular lung disease or ventilation problems. Related to the end-tidal CO2, it's normal to decrease during the cardiac limitation patient testing and also during the interstitial lung disease. The problem is with the ventilatory inefficiency with the COPD patient that due to the air trapping mechanism might have an increase or a stable pulmonary end-tidal CO2. As I was mentioning previously at the beginning of the session, I was saying that the reasons for stopping the exercise stress test are mostly related to leg fatigue when we speak about cardiac limitation. When we speak about pulmonary vascular and interstitial lung disease, it's mixed with leg fatigue and also signs of dyspnea. And mostly when we speak about COPD patients, we will see that they accuse dyspnea. The respiratory exchange ratio, which basically shows the anaerobic threshold value, usually exceeds 1.1 in maximal effort in cardiac limitation. Also in interstitial lung disease, it exceeds 1.1, but in ventilatory diseases, it doesn't manage to get to the anaerobic threshold. So the respiratory exchange ratio most of the times will remain below 1. The ventilatory efficiency, when we speak about the export of the VCO2, the VE to VCO2 slope, as I mentioned to you, almost in all conditions will be increased over 44. And also, if we speak about the ventilatory reserve, it's important because it's quite a differentiating factor. It's important to take into consideration that in cardiac limitation, we have ventilatory reserve available, and in pulmonary limitation, the ventilatory reserve is decreased or even absent. The only point where you would see the ventilatory reserve it's decreased or absent in a normal subject, it's in healthy, ultra-trained athletes. Because with highly trained athletes, also you have the adaptation of the heart to higher demands. With the changes that we spoke about, the dilatation of the right ventricle, the dilatation of the left ventricle, the atria, in order to ensure a higher cardiac output. And you also will see in highly trained athletes that they will reach also to their maximum voluntary ventilation. So it's possible that they won't have any ventilatory reserve. And if we speak about the ventilatory threshold, as we said about the rare, it's present in cardiac and pulmonary limitation, and it's absent in ventilatory limitation. And VO2 max, generally speaking, should be low in all conditions. And now I'll conclude basically with this slide that I've put related to the management of the general management of a patient that it's tested with a cardiopulmonary exercise test. And I like to underline again the importance of the VO2 in starting the differentiation between the pathologies, then the if the VO2 is okay, going towards the anaerobic threshold. If the anaerobic threshold it's okay, then search the breathing reserve. Okay, if the breathing reserve is not okay, then it's a pulmonary limitation. If the breathing reserve is okay, then it's basically a deconditioning. If it's not ischemic heart disease or other factors that are monitored also with the ECG. And if the anaerobic threshold is decreased, it's clear that the heart is not capable of pumping enough oxygen to ensure it, and we get into a metabolic acidosis metabolic state, and it's a cardiac impairment. Even if there is no pulmonary reserve, then it means that it's both conditions that are affecting the specific patient. And I think we could take some more questions, and I think that we could organize a case session in terms of normal, in terms of different different pathologies, a dedicated session in which we could explore more the advantages of doing the CPET test, and maybe to discuss also about the recommendations in exercise and recommendations in cardiopulmonary rehabilitation. Thank you very much.
It's clear that for sure we will need another session. I will go to the questions, and first one: how to determine the suitable and safe CPET protocol for patients with comorbidities, for example, obesity?
Generally speaking, this is the protocol that you decide during the setup of the equipment. I'm a big supporter of the cycle ergometer testing, although, as I said, you will have a reduced VO2 with 10, maybe 20% than the VO2 that you would obtain on the treadmill. It's much safer, especially for the obese patient. On the other side, it's related to how you define the specific evaluation protocol. If I do this test on an obese patient which is young, I would define the step stage maybe around 40 watts per minute if it's young until 35 years old. If it's over 35 years old, I would do it around 25, 22 watts per not per minute, per 2 minutes in terms of increase of the effort. On the other side, if the patient is a woman, I would standardly do 20 watts at 2 minutes, given the risk of vagal reactions. And also, it's quite important when you configure the recovery period to try to do also a 5 minutes recovery. Not a steady stop with the load that the bike had or the treadmill had, with a steady stop in order to reduce as much as possible the risk for vagal reactions. Most of the patients that are obese are also deconditioned. Most of them are also prone to vagal reactions, and this is my advice related into managing them, except you have big muscles and you're able to support them.
Another question is related, in fact, with the room for testing. If there are any standards for the room size, or except the window needed or efficient air control.
Related to the room size, I would say that I have two laboratories in the public and in the private practice, and both are around 20 square meters. And I would say that I really think that 20 square meters is the minimum limit for a decent room for the evaluation of a patient. You will see that after you do a test and you are in the room, maybe with an assistant, if you start recalibration, if you will be in a smaller room, you will automatically receive an error related to the VCO2 from that room. And this is an aspect that is quite important related to the number of persons that should stay in the room during the stress test. Another aspect is related to the temperature. I would say that in the temperature in that room should be around 25 to 27 degrees Celsius in order to allow a proper management, in order to be as efficient as possible the analyzer. Keep away from a heat source the system, because it will damage rapidly the system, and I'll tell you from personal experience related to this aspect. So if you have heat systems, don't put the system near them.
Thank you. Another question. Can we predict the ischemic heart disease with significant coronary lesions from oxygen pulse graph analysis?
Yeah, the idea, I don't know exactly if it's the proper term to say that we can predict it. Normally speaking, if the test is performed accurately and the patient is conducted, I would say, to the highest intensity that he can manage, we could take into consideration that if the lesions that he has on the coronaries have hemodynamic impact, we will see probably a plateau of the O2 pulse. I wouldn't say that I've seen a decrease of the O2 pulse of such a patient, because somehow also the decrease of the O2 pulse should go towards also with the decrease of the blood pressure, and this is as I was mentioning earlier, a sign for termination of the test. It's a good concept, but still it's something that needs to be, I would say that it needs to be further studied. In terms of ischemic heart disease, when it's heart failure, when you say that he has dysfunction, you clearly see that the O2 pulse plateaus rapidly, and then the effort stops rapidly. This is somehow the correlation.
Okay, thank you. Another question. After the test, there are certain relaxation techniques that could be easier to the patient to return to the pre-test vital sign. Maybe a kind of breathing technique or something like this.
After the test ends, usually I leave the patient for 2-3 minutes with the mask on in order to monitor also the recovery period, also with the ECG monitoring. In terms of his recovery, I would support the idea to continue doing that activity with decreasing load, progressively decreasing load, in order to make him come back to the steady state progressively. I'm not doing any other things related to the relaxation, because I monitor also the pulmonary results, the ECG, and the blood pressure, on how is the blood pressure also coming back. It's important to take into consideration that we also have the heart rate recovery indicator, which is quite important after we finish. Basically, if you finish the test and you stop the exercise, to have basically around 12 beats per minute reduction in the first minute post-exercise, because this is also an indicator of the chronotropic function of the heart, and it's a marker of prognostic of the patient, this heart rate recovery rate. So some of this, but not specific exercises for recovery.
Thank you. Another question: for sedentary untrained patient, do we need to do the CPET twice to get the learning effect?
The learning effect for the patient, in order to make his best result, I would say. No, in my opinion, it would be good to make the test at the moment 0. I don't know when you start. First of all, if you after you do that CPET test, you usually have some specific exercise recommendations that you are making. For example, if the patient needs to lose weight, you see exactly on the, I don't know, I don't think I have the images with the calorimetric evaluation. You see, for example, at 110 beats per minute, you are most efficiently in burning fats. So you prescribe the exercise for the subject depending on his targets. For example, if he is a cyclist, you have the anaerobic threshold. You establish the rates where he needs to stay for constant load, where he needs to go for interval training. And afterwards, I would support and I would suggest for at 3 months or 6 months to do the second test, then probably yearly.
Thank you. Another question. When is the exact time for one patient who takes pharmacotherapy like beta blockers or bronchodilatator to do the CPET exam for measuring the target heart rate using the heart rate or bore scale, RPE?
I would say that if the patient takes beta blockers, somehow it depends the reason on why you are doing the test. If you are doing the test to search the electrical stability of the heart, to search that the heart it's okay, and to see exactly what is the performance of the heart with the beta blocker medication, I would suggest the test to be done around 2 hours from the beta blocker administration. If it's related to the inhalers, the idea is somehow the following. If you take inhalers, probably you have some level of obstruction. It's important to associate the spirometry, very important to associate the spirometry in terms of this patient. Usually after the test, if you don't take any inhaler, after the test, the post-effort spirometry that can be done might show worse results because we are speaking about the effects of training, about these effects of air trapping during effort. I would say that this decision in which to do the test, it's related to if you want to see after the inhaler, if the patient performs better, you should do without it, then you should do with it. And afterwards, basically, it comes to the decision on the optimization of the performance of the specific subject in terms of what he is holding on, to try to do it, for example, you do it's a fast acting, then you do it directly. If it's a long acting, I will do it at 2-3 hours from the administration of the dilator.
Thank you. Another question. Is there any possibility to interpret the risk stratification of heart disease if CPET is completed with a peak RIR under 1?
Generally speaking, the risk stratification of heart disease if CPET is completed with peak RIR under 1. The risk stratification is done, as I told you, by the VO2 level. It's not a risk of the heart disease or the general risk of the patient. It's shown by the VO2 that it obtains. I wouldn't say that we would be able to, we will see that the major problem that the patient has, it's the pulmonary limitation. And this is quite important to be tackled by that specific patient. But on the part of the heart, I would say that the heart isn't stretched enough in order to see exactly if it could manage to make face to the challenges if the lungs were normal or not. And because that's one of the reasons that I was mentioning in the table that I've shown, that if you have a pulmonary limitation, you don't manage to get to the RIR of 1, and you also have a high heart rate, a large heart rate reserve. So you don't manage to stretch the heart in order to see exactly how it manages to cope with the stress. But you obtain a low VO2, that means that you are a higher general risk of mortality, because somehow VO2 is correlated with the overall mortality.
And message, thank you very much, Dr. Stefan Bosnatu, for the interesting lecture. It really was an interesting lecture, and on behalf of BTL, thank you too for staying with us today. I think there are not any questions. So thank you again for this presentation. Thank you all